This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending in Neurosurgery.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the journal Operative Neurosurgery, published in 2026. It's a technical note titled Novel Intradural Endoscopic Lumbosacral Ventral-Dorsal Rhizotomy, a technical note with operative video.
This is a really interesting one, Ilara. We're talking about a first ever here. The first reported endoscopic lumbosacral ventral-dorsal rhizotomy, or VDR. It's a procedure that addresses a very specific and often very difficult patient population, those with medically refractory hypertonia and severe spinal deformity.
Exactly. To set the stage for our listeners, we usually see pediatric movement disorders, or PMDs, manifesting as hypertonia from conditions like cerebral palsy. Our standard tool belt includes bracing, physical therapy, antispasmodics, and intrathecal baclofen, or ITB. But when we get to surgical intervention, we usually think of selective dorsal rhizotomy, or SDR.
Right, but the paper makes an important distinction there. While SDR is a gain-of-function surgery for ambulatory patients, those in the Gross Motor Function Classification Score, GMFCS, levels 1 through 3, it's often less effective for patients in GMFCS levels 4 and 5, especially when dystonia is part of the mix.
That's where the ventral-dorsal rhizotomy comes in. Unlike a standard SDR, which focuses only on the dorsal roots to manage spasticity, a VDR involves sectioning both the ventral and dorsal nerve roots. The authors note that while ventral root sectioning is effective for tone reduction, it isn't currently considered a gain-of-function surgery because our understanding of ventral rootlet selectivity is still somewhat limited.
Historically, VDR has been a microsurgical procedure, or sometimes performed via fluoroscopy-guided radiofrequency ablation, which was quite popular in the 70s and 80s. But we run into a major roadblock when a patient has severe rotatory scoliosis or a previous spinal fusion. In those cases, a traditional open microsurgical corridor or a safe needle path for RFA can be technically impractical or even impossible.
And that brings us to the clinical presentation in this paper. This was a 21-year-old non-ambulatory male, GMFCS level 5. He had spastic, dystonic quadriplegic cerebral palsy, global developmental delay, and Lennox-Gastaut syndrome. Most importantly for the surgical planning, he had severe neuromuscular rotatory kyphoscoliosis and a previous posterior instrumented fusion from T3 down to the pelvis.
His hypertonia was severe, a modified Ashworth scale of 4 in all muscle groups, bilateral upper and lower extremities. The family had already tried an ITB bolus test dose of 100 micrograms, and it was ineffective, so they were looking at very few options.
When the team looked at the CT scans, the rotational deformity and the existing spinal hardware essentially obviated any approach other than an endoscopic one. The authors described this as an unmet need that drove their innovation.
Let's get into the technical details of the surgery, because this is where the technical note really shines for our resident and attending listeners. They positioned the patient prone on gel rolls and used standard EMG monitoring, specifically targeting the iliopsoas, vastus lateralis and medialis, biceps femoris, tibialis anterior, gastrocnemius, peroneus longus, abductor hallucis, and the anal sphincter.
The approach was a 6-centimeter midline incision along the old fusion scar. They performed a bilateral paraspinal dissection at the L3 level, centered at the spinous process. They used a 5-millimeter fluted drill followed by a diamond ball to create the surgical corridor. After resecting the ligamentum flavum with a Kerrison punch and using bone wax for hemostasis, they made a 2-centimeter durotomy.
Now here is the core of the innovation. They introduced a flexible neuroendoscope from Karl Storz. They used continuous irrigation to maintain visualization within the fecal sac. This is a very different environment than an open microsurgical field.
What I found most interesting was how they identified the roots. In a traditional VDR, you have a wide exposure. Here, they used mechanical endoscopic manipulation of the nerve roots to elicit free-running EMG in the corresponding myotome. If the electrophysiology was ambiguous, they used fluoroscopy to confirm the root level.
It's a clever use of the tools available. Once they identified the L1 through S1 mixed nerve roots, they used a Bugbee electrocautery. They set it to a level of 10 and applied it for approximately 5 to 10 seconds per root.
They actually defined a specific metric for the ablation, which they called the extent of ablation, or EOA. They estimated this volumetrically by watching for the ablation-associated color change across 80 to 90% of the nerve.
That's a key detail for reproducibility. Once the ablation was complete, the closure was fairly standard, running 5-0 Gore-Tex for the dura, then T-seal and gel foam, followed by intra-wound vancomycin powder and a layered closure.
The stats on the case are impressive for a first-of-its-kind procedure. The total case duration was 233 minutes, and the estimated blood loss was only about 5 milliliters.
And the results?
Quite dramatic. Post-operatively, the patient's modified Ashworth scale was reduced to 0 in all muscle groups. The authors also highlight that the physical examination video showed an improved sitting position with neutral spinal alignment and enhanced sitting balance.
That's a significant palliative outcome for a GMFCS5 patient. By reducing that global hypertonia, you're not just making the patient more comfortable, you're making daily care, hygiene, and positioning much more manageable for the caregivers.
The authors conclude that this endoscopic VDR is a safe and effective methodology for tone reduction in patients who otherwise have no surgical options due to their anatomy. They're encouraging other surgeons to expand on this through continued innovation.
It really highlights how neuroendoscopy is moving beyond just the ventricles or the skull base and into the intradural spine in ways we didn't necessarily prioritize a decade ago. For residents listening, the Lessons Learned section of the paper specifically mentions the importance of visualization, the nuances of root selection in a rotated spine, and being precise with the extent of ablation.
It's also a reminder that even in a palliative context, the technical demands are high. Using flexible endoscopy intradurally requires a different set of hand-eye coordination than the operating microscope.
Absolutely. Well, this was a concise but high-impact technical note. A great example of solving a complex anatomical problem with a minimally invasive approach.
If you want to see the technique in action, the paper includes an operative video, which is highly recommended.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Ilara. We'll see you in the next episode.